Hi, ladies and gentlemen. Thank you for joining our e-seminar today, Parkinson's Disease, Changing the Way We Look at Balance in this Patient Population. We're delighted to welcome you to this course. If you may have noted, your line was muted on entry to the virtual meeting room, and this is done intentionally to keep background noise to a minimum during today's presentation. If you have questions during this presentation, will you kindly type them into the chat box located here on the right-hand side of the screen, and I'll moderate your questions for our guest speaker at the end of the presentation. Today's lecture is being recorded, and you'll automatically receive the recording link along with a PDF of today's presentation. Without further delay, I'm honored to introduce today's speaker. Kenda Fuller began her practice in 1979 after graduation from the University of Colorado Health Sciences Center. Her first introduction to physical therapy was in the rehabilitation setting, and she followed that interest through work in a community setting at Lutheran Hospital, Harvard University-affiliated Brigham and Women's Hospital in Boston, and the University of Colorado Hospital. Ms. Fuller was the first ABPTS certified neurological specialist in Colorado, and she was instrumental in the establishment of the neurological section's Stroke Special Interest Group and as the first chairman. As a founding member of the Vestibular Rehab Special Interest Group, she has been a leader in the integration of this specialty into the practice of physical therapy. Teaching has been a strong component of her practice as adjunct faculty at University of Colorado's Program in Physical Therapy, Regis University Department of Physical Therapy, and Rocky Mountain University. Ms. Fuller is a co-owner of South Valley Physical Therapy, the largest PT private practice specializing in neurological care in the region. Without further delay, I'd like to turn the presentation over to Kenda. Kenda, the presentation is now yours.
Thank you, Teresa. I'm happy to be doing this. Obviously, I've been in this realm for a long time, and I'm happy to see how many people are participating today, and I hope that I know a few of you. So my topic today is changing the way that we look at balance in this population. So my objectives are to look at the deficits in the limits of stability and strategy selection in the population with Parkinson's disease, because I think that that's often left out of our evaluations. The next thing I'd really like to have everyone understand is the role of the visual dependency in patients who have Parkinson's disease. And this will become clearer as I go through the lecture. And the other thing that we've been doing in our clinic is using perturbation training during the interventions for individuals who have Parkinson's disease. So we know that balance in daily life is a very critical piece for all of us, and as I said earlier, the people who have Parkinson's disease, there's a subset of them that tend to fall more than the others. Now, I would imagine that everyone on the line is familiar with the postural changes in individuals with Parkinson's disease, including decreased mobility of the spine, increased kyphosis of the upper back, forward head, decreased ankle mobility and strength. And what we also are aware of is that there is typically poor control of the trunk when supported on a single leg. So our question is that where the cause and effect of this is are these just due to the changes in the basal ganglia, or we see these same characteristics in our patients over time who have poor use of their vestibular system? So is the lack of the vestibular responses driving increased postural changes in our patients who have Parkinson's disease? So I'm going to talk about the components of balance in relationship to the individuals with Parkinson's disease. So we know that we use our visual reference for balance by using both horizontal and vertical references to determine our head positions. We can identify movement, our self-movement, in a stable space when there are clear horizontal and vertical references available, but we cannot determine self-movement from movement in the environment using our vision when there is movement in the environment. We also, if we are dependent on our visual reference for balance, we will have more imbalance with our eyes closed. And for all of us, if we close our eyes, we're going to feel a little less stable because we typically use our vision so highly for our balance references. So when we are all more cautious in environments with visual stimulation, airports, malls, big stores, if you go to the top of the Hancock Building in Boston and you look down over the city, most people will feel a little less steady. So those patients who become dependent on their vision will be dependent on their peripheral visual cues for stability. And this is a very important piece of this as we move forward. And the patient is imbalanced when the visual environment moves or if it appears to move. So there's a phenomenon called physiologic diplopia. And if you put your thumb up in front of you, and I want you all to do this, put your thumb up in front of you and look at your thumb, and you'll notice that everything behind it appears to double just a little bit. And that's a normal phenomenon. And we extinguish that background change in the environment and maintain our gaze on our thumb, and we don't even record or respond to that change that happens behind our thumb. If you move your thumb back and forth and you track it with your eyes, you will see that the background will appear to move slightly. So if we are tracking something with our eyes, our peripheral visual field will appear to move, and that is perfectly normal. But if you are dependent on that peripheral field of view to know where your head is in space, you're going to feel imbalanced or destabilized. So what happens to these individuals is that they have a reduced ability to separate central vision from peripheral vision. And I'm going to talk about that just a little bit more in a moment. So what do we do with these patients who have visual dependency or this sensitivity to apparent movement in their peripheral field of view? We're going to work to maintain balance while changing the visual reference in the environment. We're going to work on activities such as convergence and smooth pursuits because they create that physiologic diplopia. And diplopia, for those who don't know, means double vision. We're going to move the head to create a visual flow and help the patient stay balanced during that visual flow. We know that our patients who have vestibular problems, we have them walk and turn their head to create that visual flow to activate the vestibular system. We will do it very systematically using optokinetic stimulus in our clinic. I'll share that in just a moment. And with these patients, it's very important to look up. I've spent my entire career walking with patients up and down the hall in the hospitals, telling them to look ahead and not look at their feet. Well, part of that is that if they're using their visual system for their balance, they need to look up so that they have good visual cues, and looking down at the ground will actually disrupt their use of the vestibular system for their balancing. So an easy way to do this, to decrease that visual dependency, is to have someone stand and track their eyes with their thumb. So you can do this in double stance. We're doing this here with one foot against the wall, and this patient is following that figure of 8 with her thumb, and you can see that her head is pulled off reference because she's using her peripheral visual cues, which appear to be moving, in preference to the vestibular reference of gravity, which would hold her head in a neutral position. So what we're trying to train the patient to be able to do is to manage that perceived visual motion in their environment and allow them to go back and use their vestibular system more efficiently. So the other thing that we do is use optokinetic stimulation in our clinic. So in this slide, you can see that there is a ball with horizontal stripes on it hanging. It's actually hanging from a fishing line in the middle of the room. And in the background, we are moving lights, and we use an old standard disco ball from the 70s and the 80s to put light to the peripheral field of view. So the distance between where that ball is hanging and the wall is about 4 feet, and then the patient is 3 to 4 feet from the ball. And we turn the lights down. We want to get as much distinction between the light and the dark as possible, but the patient's goal is to look at the ball and hold that central gaze stable. So we turn the lights on and we have them moving from the floor to the ceiling, which will typically make a patient feel like they're going to fall backwards. And that's the direction that most people fall when they have Parkinson's disease. So we are training them to use their central gaze and to ignore the movement of the peripheral field of view and use their vestibular system to maintain their head in a stable position. We do this for about 10 minutes. So research shows that if someone can maintain this optokinetic flow and not have that cause a loss of balance for 10 minutes, their balance is normalized using their vestibular system. So this is something that we do in the clinic. We have a room that's actually the right size to set this up, which can be a typical treatment space. If you have the Smart Equitest, then you can use the surround of the in the Equitest, giving the patient initially information about where their body is in space as you randomly move that surround or randomly move the visual reference around them, and then eventually take the cursor away, have them move, and then you can give them that delayed feedback of how stable they were while they were performing that activity. So that's another way to activate the peripheral field, changing the reference in the peripheral field of view. So we work a lot with our patients to decrease their visual dependency for balance. That's the first direction that we go with our patients who have Parkinson's disease. Then the second piece that we look at in our patients who have Parkinson's disease and imbalance is looking at how much they're using their body reference for balance. So if you're using your body reference, you're using the surface reference to determine your body position. So the head position is actually determined by the stacking of joints. And this allows an internal representation of how far the body can move over its base of support before changing the support or losing balance. And we'll talk about that in just a minute when we talk about ankle, hip, and stepping strategies. So we know that people who have Parkinson's disease have a somatosensory disorder. It's mild, but it's persistent. So they will try to use that surface reference to determine body position, even though it's not a very accurate reference for them. And again, we talked about position being determined by stacking of the joints. And what happens then is that the individual will use a muscular co-contraction to stabilize the head on body and the body to the surface. So we know that with Parkinson's disease, co-contraction around a joint is a major issue for these patients. Again, this is cause and effect, what's driving this. So we don't want our patients to use excessive muscular co-contraction to stabilize, because that's already a deficit that's a part of Parkinson's disease. So we note that our patients who have a vestibular disorder, young or old, will increase the stiffness in their neck in order to know where their head is in space. So our interventions are driven toward decreasing the somatosensory referencing in order to increase the use of the vestibular system, because that's our goal here. So we will often do body rotation on head. And we do this with our patients sitting in a swivel chair. So we have them use a mirror to hold their head in a central position visually as they rotate the chair underneath them. And this is very difficult for many of our patients to perform. But it's a very simple way to get started with these patients. It makes them aware of their ability to move their body outside of the reference that their head is in, and to be able to maintain their head in a position related to gravity reference while the body is being rotated underneath. We also tilt the surface under the head. So we'll have somebody sit on a tilt board, having them standing on tilt boards. That's a great way to do this, looking to see if the head stays in reference to gravity rather than moving with the body, causing that imbalance. We do a lot of work with sit to stand. We know that people who are able to go sit to stand without the use of their hands have less risk of fall than individuals who require the use of their hands to stand up. So we do this in combination with our visual dependency, and we have our patients go from sitting to standing with a focus on getting the tibia over the forefoot so that they have appropriate somatosensation, and they're not pushing back into the chair to stand up, and we have them do this with their eyes closed. The other thing that you can do is put a different surface under each foot. So just putting one foot on a piece of foam that might be 2 or 3 inches deep will allow a patient who, the way the brain uses this surface reference under each foot is it compares the pressure on one foot compared to the other. So if you take the pressure off of one foot, then that also drives increased use of the vestibular system. And most of our patients can do this without a lot of difficulty, and we can set them up with their backs to the corner, put one foot on a piece of foam, the other foot on the ground, and see if they can learn to maintain their balance without having both feet on the ground. And it's another way to drive vestibular function. Because that's one of the things that we want to do in our clinic, is to try to get the vestibular function in these patients to be as high as possible. Because gravity is our ultimate self-reference. It never turns off. You can't change gravity. So that allows us to maintain this vertical reference when the surface is unstable or moving. It also allows us to have balance when the lights are low or the vision is otherwise disrupted, as we just talked about with the optokinetic flow or the visual flow with head motion or tracking. And it is activated when performing, when walking and performing 180-degree or 360-degree turns. So we do a lot of work with walking and turning, because these patients typically fall while they're making a turn or changing surfaces. So what we know about vestibular rehabilitation in this patient population is that it is shown to be effective in improving the activities of daily life, gait velocity, and balance, as well as reducing risk for falls. And these benefits persist over a 1-year follow-up. and I've given you the reference here. So I think that looking at the vestibular component of individuals who have Parkinson's disease is a new and very exciting part of the research environment. So the vestibular system works through the labyrinthine reflex, keeping the head in vertical in response to gravity during the tilting of the body or the surface. One of the very important parts of this, and again, I believe this is both cause and effect, that in order to have head riding, we have to have mobility of the upper cervical spine, which is often very stiff and restricted in our patients who have Parkinson's disease. So we work on both creating mobility of the upper cervical spine and maintaining that by working on head riding activities. And we do that by having the patient reach side to side to activate the head riding response, sitting on tilt boards, sitting on a ball if they have enough stability. We have them work on tandem stance or semi-tandem stance. And again, we need to be giving them input, and they have to have the ability to move their upper cervical spine in order to achieve the degree of head riding that's normal for tandem stance. People who have balance disorders, therapists around the world are putting them in tandem stance to activate their balance response. But if you hold your head in a 90-degree reference to your shoulders, you will always lose your balance when you're performing tandem stance. So when you're looking at your patients who have Parkinson's disease, you need to look at their ability for the skull to move on the top of the cervical spine in order for them to use their gravity response. So in reality, as we all know, that the integration of these three systems are very critical in our patients, and we work with them depending on what we think that they need. And we are dependent on the environmental conditions. So what the person with Parkinson's disease typically does is to stay in their safest environmental condition, but they're going to fall if they step beyond that. So we're trying to widen their box, increase their environmental capacity to work in more complex environmental conditions. The brain is going to select the most efficient system. So if your brain knows that you don't have good head riding, you will choose another reference in order to maintain your balance, either vision or somatosensation. So we have to make the vestibular system efficient in these patients. And the brain will always substitute another system if one is not functional. So if the brain cannot use the vestibular system, it will always go off to another system. So this is why we see patients who need to have good visual cues and will use their upper extremity to assist in keeping their head in a neutral position. And the other thing to think about in these individuals is that the integration is constantly moving. You don't get there and stay there. You're constantly moving around. So we use the dynamic systems model. I'm going to go through this very quickly. We're comparing the sensory system to the motor system. I mean, we're looking at the process between the sensory system and motor. So we want to know how we're using the visual vestibular somatosensory system in relationship to the motion of the lower extremity, trunks, and eyes. So we use that to compare, select, and combine the sensory input available in order to choose the appropriate muscle contraction. Then we have to know which environment we're in and what is it that we really need to do. So that sensory motor piece is very important. And then we're looking as well at the anticipatory postural adjustments. So this system is looking at the tasks that require an active movement of the body's center of mass in anticipation of a postural transition from one body position to another. So when we look at that, we wonder if this typical narrow stance that we see with our patients who have Parkinson's disease may be compensation for the inability to sufficiently increase the size of the lateral sway to allow this fast step initiation, to get that first step in this wide stance. So they may narrow their base of support in reaction to the fact that they can't activate efficient lateral sway. So looking at sway patterns through the hips is another very big part of what we do in our practice. So what we know about the motor control changes in an individual who has Parkinson's disease is that the reaction time increases. They're slower to perform. They have their balance performance with difficult motor tasks decreases. There is decreased adaptation with repetition. So we learn with repetition. And what we find with these patients is that they don't learn with repetition. There is slower voluntary response. So a great individual I know who has Parkinson's disease says at the beginning of his lectures, if you want me to slow down, tell me to speed up. So what we know is with more effort, the responses actually slow down. And then we understand this reduced excursion of movement. And our question is this due to the rigidity, the postural changes, or is it due to the fact that the patient is no longer using their vestibular system in the way that it should? So we know that control of the center of gravity is a big part of what the vestibular system does. And we see this, and I don't have to tell any of you about this. There are decreased limits of stability. There's an increased sway while they're trying to stand quietly. The weight is held forward, and they lose balance then when they're perturbed backwards. And these patients will typically use their upper extremity to try to control the center of gravity, which we know is not very efficient. So this woman has a delightful limit of stability. We don't typically see that in our patient population. But limits of stability training is a great way to get these patients moving better, and we use that quite a bit in our clinic. We also look very carefully at the strategy selection. And I think now in our practices we know a lot about the use of strategy selection for balance, and we need to be looking at this very carefully in our population of patients who have Parkinson's disease. So the ankle strategy is our primary reference for keeping balance when we are on a large and flat surface. There's a very small excursion of our weight shift using our ankle strategy, just from a biomechanical perspective. The head and body move in the same direction, and the firing pattern to the brain is distal to proximal. So we use a combination of an ankle strategy and a hip strategy when we're doing an activity such as reaching. So the hip strategy is something that we use when we're on an unstable or a narrow surface. It's preferred when the perturbation is larger and rapid near our limits of stability. So you can see as that woman was reaching into the cupboard, she started with an ankle strategy and then shifted into a hip strategy so that her body looks like this cartoon here as her hips are backwards and her chest is forward. The muscles are recruited proximal to distal, so the hips, abdomen, trunk is recruited before the ankle is. And this head movement is out of phase with the hips, and I'll talk about that a little bit more in a little while. In the stepping strategy, we always look to see if our patients have an adequate stepping strategy, even though it's the third line of defense, because we know that their ankle strategies are fairly limited. So the stepping strategy is what is going to prevent a fall. It's creating a new base of support as the center of gravity goes outside of the limits of stability. And we use a stepping strategy when the perturbations are fast, large amplitude, or when our other strategies fall. So the stepping strategy is really the fail-safe. And we tell our patients that they need to know which direction their head is moving, which is the vestibular response, in order to know where to put their foot in order to prevent a fall. So looking and documenting all of these strategies we feel are very important in our clinic. And we know everybody learns them in the PT curriculums now, but we don't typically talk about them or document the use of ankle, hip, or stepping strategy as we're describing our patients. So typically what happens in the individual with Parkinson's disease is that they lose their full range of an ankle strategy, so their limit of stability is reduced. They will rely on a hip strategy on a firm surface, which is very inefficient, but you'll see this very often with these patients. They will have a decreased use of stepping strategy. Part of that is this issue of initiation and lateral excursion of the center of gravity through the hips and pelvis. But it is also that if they're not sure which direction their head is going, they don't know where to put their foot. And then these patients have a really strong startle response in that they want to use their extremities to respond to a perturbation before they allow themselves to use their gravity reference or their vestibular system. So one of the things that we're starting to look at in the population of both vestibular and Parkinson's disease is perturbed surface training. And those of you who have a smart Equitest know that you have a lot of control over the movement of the surface underneath the patient's feet. And we think this is ideally used in the population of patients who have Parkinson's disease. But you need to look at how the patients are moving. So we talk about this now as in phase, where the trunk and the legs move together, or out of phase, which means the trunk and the legs move in different directions. So if we are doing a perturbed surface training, our patients need to be able to move out of phase. So if you look at the line drawing here of the relationship of the trunk to the upper leg, so this patient is keeping her lower legs fairly perpendicular, but in order to keep her balance, her hips are going backwards and her trunk is going forward, which looks like a hip strategy. So perturbation training, we believe, is a very good way to activate the hip strategy in an appropriate setting. So even small shifts can be very effective. What you see in the abnormal patient, so this would be a normal response. It's a little bit, the only problem here is that the trunk should stay in the upright position as the lower extremity makes these adaptations. And so this is someone who is moving with the surface. So you can see that her head moves with that perturbation, or the tilt of the surface. She's moving toward the A on the platform, away from center. So we see patients who overuse a hip strategy to try to keep their head referenced to the surface, or they will move in block so the whole body shifts forward, and you can only maintain your balance to 8 degrees if you're working if your head is held with your lower extremities on a perturbed surface. So what happens to our patients with Parkinson's disease is they have a decreased ability to maintain the trunk and head in a gravity-neutral position. There's a decreased control of amplitude and velocity, which results in a loss of balance. And as you saw in this previous slide, the head follows the tilt of the surface, so the postural control mechanism is adequate. So you can only maintain your balance to an 8-degree tilt, which isn't even enough to go up and down stairs. So that's my main talk about how we are looking at the integration of the visual, somatosensory, and vestibular references in our patients who have Parkinson's disease. And I think it has an effect on all of these other things that we're going to be talking about. So we also have to look at strength, coordination, reactive responses of upper limbs while lower limbs are doing balance tasks. We all know that we need to look at cognition during balance tasks, and we believe that that also has a correlation to the vestibular system, because we know that people who have poor vestibular responses also have poor cognition during activity. So we train these patients by having them do a cognitive task, counting backwards, using the alphabet to represent names or animals. So we believe that for our patients who have Parkinson's disease, that having them doing a cognitive task during balance will also help to activate the vestibular system. So our patients are always doing some secondary task while we're retraining their balance. And then the other piece that I think is also very common and people understand this, that there's a lack of trunk rotation. And part of that, we believe, is due to that somatosensory referencing, where the brain wants to use the reference of the head to the shoulders through the trunk to the pelvis. And if we can get the vestibular system working better, we have noticed that we've been able to uncover increased trunk rotation in our patients. So this is the other thing that we just need to be aware as we're looking at all of that, is that change of speed are essential for adaptation. We know that somebody who has a vestibular disorder has difficulty changing speed of an activity. And as those of you who use the functional gait assessment know that changes of speed is a piece of that exam, and that's really looking at that from the perspective of the vestibular system. We know that external cues work best, which is why we love to have external references that we use in our clinic. We use the metronome all the time. We look at constraint-induced, and I think that the constraint-induced, the best way to look at that is using body weight support treadmill training. So we are having our patients walk backwards. They're doing a lot of research right now in the realm of Parkinson's disease with having patients walk backwards. And we believe that walking backwards actually helps to activate the stepping strategy, because there is this change of orientation of the head to the foot placement. We see an increase in that lateral weight shift, which we think is important for initiating a step. And this also gives them a cognitive challenge, because walking backwards feels very differently to them than walking forwards does. So we know that exercise trumps all, but we do believe, and the research is certainly moving in that direction, but we believe that the exercise needs to be directed in some of these specific areas, looking at limits of stability, looking at strategy retraining, increasing flexibility and strength, which we've all been doing for years, and it can't go away because it's a critical part of this, especially at the area of the upper cervical spine and base of the skull to allow a riding response. Decreased use of the upper extremity for control of balance. We need to have them improve their ability to make safe turns, which is lateral weight shift and visual flow. They need to decrease their visual dependency and increase the use of head turns during their tasks, because we believe that will make them they'll have less chance of falling. So we've been talking big with our patients who have Parkinson's for a very long time, and I'm not going to go into that whole movement, but we know that expanding these movements, going overhead, going behind, increasing step length, which is what the body weight support is wonderful for, incorporating rotation in the upper body. So one of the things that we love to do with our patients, because they need to have motivation and a little competition, so we will often have them throw a ball as far as they can throw it and see if they can throw it further than they did the next time, because that includes all of this: expanded motions, overhead, and in order to throw a ball, those of you who play baseball, you have to step forward and you have to rotate that upper body. So something as simple as that is a great motivational tool for our patients. Of course, you have to have them throwing a ball where they're not going to hit somebody in the head, but that's something that can be worked out. So I'm just going to briefly talk about neuroprotection, because those of you who follow the Parkinson's literature know that neuroprotection is the biggest word in Parkinson's right now. So these activities will drive neurogenesis. It increases the dopamine synthesis. Exercise does. It creates new synaptic connection. It decreases the neurodegeneration within the basal ganglia, and it increases the use of other parts of the brain. And in looking at this, we understand that there is a whole glutamate system that is effective in the brain that is outside of the basal ganglia and the dopamine system. So we believe that that might be what is also helping to drive the neuroprotection in our with these big activities that we're doing. The other important thing for our patients who have Parkinson's is to learn something new every day. That's why we try to put this cognitive piece into our interventions. And these are new movements that we're asking them to do. Having them have an opportunity also to do some meditation to quiet their brain down is also important. So we do a lot of settling. We have the patients quiet themselves down because we know that the basal ganglia is creating more activity in their system than they need. And this option to be creative. So one of the things that we really try to do with our patient population is to come up with as creative a home program as we can come up with. When I first started working with people who had Parkinson's back in 1979, the only thing we had them do was range of motion and stretching, which is clearly important, but it was the most boring program for them and for us. And we tell our patients that we believe that it's typically not the patient who plateaus, but the therapist. So when we run out of creative ideas, that's when the patient doesn't get better. So that's just my little caveat for you in your practices. So this is my last slide. So what we really need to look at is that the program needs to match the current ability of the patient, but the goal should really reflect a new level of function. And Medicare now is looking at functional classifications and functional limitations. So this just sits with what we're talking about, but you can't get a new level of function in these individuals, especially those who fall, without addressing the visual, the somatosensory, and the vestibular system. Thank you very much for giving me this much of your time.
Kenda, thank you very much for sharing your clinical expertise and for a very thorough and interesting presentation. This will conclude the recording of today's presentation.